Good afternoon. It's my great pleasure to be invited to PULM Talk, and I'd like to greatly thank Professor Francisco Soldado and all members of PULM Talks. My designated topics is free mass transfer for elbow flexion in children. Before starting the lecture, I'd like to sincerely recognize Marian's invitation and also her contribution to our hospital during her stay in 2018. I'm going to introduce the retrospective analysis of my 40 years experience in the department, assessing in the feasibility of free functional mass transfer children, especially focusing on technical aspect of the procedure, and long-term effect on the function of the upper limb, and identifying potential problem and pitfall with free functional mass transfer in children. I personally operated 56 free mass transfer in 36 children from the total of 181 free mass transfers. Today, I represent free mass transfer for upper limb reconstruction, including brachial plexus palsy and amyoplasia of arthrogryposis multiplex. Among 34 cases today, I'll focus on 15 preschool children younger than 6 years old to clearly recognize the characteristics of free mass transfer in children. Among 15 upper limb paralysis, 4 were due to traumatic BPP, 5 obstetric, 3 acute flaccid myelitis, and 3 amyoplasia of arthrogryposis multiplex. Basic surgical techniques for elbow flexion are divided into two methods of free muscle transfer. That is a simple method in which free muscle transfer recognizes only elbow flexion, and combined method in which free muscle transfer provided two more joint motion, like as elbow flexion and finger flexion simultaneously. We used not only single free mass transfer, but also double free mass transfer for combined elbow and finger function reconstruction. I will describe our surgical techniques briefly. First, in preparation of recipient site, the favorable position of the vascular pedicle and donor muscle motor nerve were selected with respect to the recipient vessel and motor nerve. The best match combination are spinal accessory nerve and thoracoacromial artery and cephalic vein around the clavicle, and fifth and sixth intercostal nerves and thoracodorsal artery and vein around the axilla. Sometimes partial fascicles of median or ulnar nerve was used. The entire gracilis muscle with monitoring skin flap was harvested from its origin at the pubis to its insertion over tibia depending on necessary length. We recommended measuring the compound muscle action potential CMAPs for post-operative monitoring of muscle circulation instead of unreliable skin flap. I will describe the transfer techniques by dividing into simple and combined functional reconstruction. In simple functional reconstruction for elbow flexion, the harvested gracilis is attached with bone suture to the lateral end of clavicle. Neurovascular anastomosis are performed, and distal attachment of gracilis was sutured to the radial tuberosity in the position of more than 90 degrees elbow flexion. Post-operatively, the upper limb was immobilized with use of an arm brace and cast, keeping for 4 weeks, and followed arm sling immobilization until active elbow motion. During immobilization, early passive mobilization of elbow was started 3 weeks after the surgery. Surface EMG was used to confirm the innervation of the transfer muscles. The parent was educated how to take care of the children to strengthen the power of the muscle while playing in daily activities. Demonstrating 2 cases representation of simple elbow reconstruction. A 6-year-old boy with right obstetric BPP of C5 to 8 type palsy who had failed nerve graft and ICN-MCN transfer by previous doctor underwent a simple elbow flexion reconstruction by free mass transfer, of which the motor nerve was connected to the partial fascicles of median nerve and distal tendon was rerouted to reconstruct the forearm pronation and sutured to the radial tuberosity in the position of 90 degrees elbow flexion. This is a post-operative elbow flexion 2 years after operation. The next case, the picture demonstrating bilateral upper limb involvement of elbow flexion in 15-month-old boy with amyoplasia of arthrogryposis. He also had the hypoplasia of the pectoralis major and latissimus dorsi, which were used for elbow flexion reconstruction. 2-stage bilateral reconstruction were performed at about 3-month interval between 2 procedures around the age of 2 years. He could obtain satisfactory elbow flexion after surgery and could perform all of his school and daily activities without any difficult assistance. During high school age, he was able to play baseball with his friends. And now, he is working for manufacturing companies. Summarizing of long-term outcomes of simple elbow flexion reconstruction by free mass transfer children with obstetric palsy obtained satisfactory elbow flexion and mild elbow flexion contracture. Children with amyoplasia obtained satisfactory elbow flexion, but the elbow flexion contracture varied from -15 degrees to -100 degrees, depending on the power of elbow extensor. Next, the combined reconstruction of elbow flexion and finger function was performed by single or double hemorrhage transfer utilizing the long length of gracilis to reach from the shoulder to forearm. We have already reported the long-term outcome of double hemorrhage transfer for not only adults, but also children several times. Dr. Pinel visited our hospital in 2003, and I hope he enjoyed our double hemorrhage transfers. I would like to show you combined reconstruction of elbow flexion and finger function using 2 typical cases of traumatic BPP and acute flaccid myelitis BPP. This is the preoperative MRI of 6-year-old boy with traumatic BP total palsy who underwent CC7 to suprascapular nerve, PC transfer, and double humerus transfer, showing C5 to T1 preganglionic injuries. This is 16 years after surgery, and good function was maintained in this patient. The patient has persistent good shoulder function, and he has improved E-Flexion. He is also able to extend rotated shoulder and flex elbow. His finger function was maintained for 16 years. A 4-year-old girl presented with poliomyelitis-like paralysis of left upper limb following an acute attack of asthma from 4 months ago. The primary pediatrician made a diagnosis of Hopkins syndrome, which was recently classified to acute flaccid myelitis, which was pandemic also in Japan. She had a total complete paralysis of the left upper arm, but the sensory was normal. As a first stage operation, shoulder reconstruction was done by using free vascularized radial nerve graft between contralateral C7 root and suprascapular and long thoracic nerves. Four months after stage 1, we performed a gracilis free functional muscle transfer to restore finger flexion. Simultaneously, the third and fourth intercostal nerves were transferred to the motor branch of the triceps. A 3 months later, we performed another gracilis free muscle transfer to restore E-Flexion and finger extension. She had good control and could effectively use the reconstructed limb in most of her daily and school activities. She could lift a light object and perform two-handed activities like squeezing the dust cloth. Summarizing median 10 years long-term outcomes of 9 cases with combined elbow flexion reconstruction by free muscle transfer, median ranges of elbow motion was 140 degrees in flexion and minus 35 degrees in extension. Finger total active motion was 60 degrees. These functional results were tremendous success for elbow flexion compared with previous palliative technique like as tendon transfer. You may be concerned regarding of the feasibility of free muscle transfer for small children like as preschool children, especially about microvascular anastomosis and nerve suture. Free muscle transfer in children may seem more challenging than in adults because of small size of vessel and nerves. However, we did not experience any failure and achieved higher procedure success rate than in adults. The diameter of vessel is large enough to connect by standard microsurgeon like me, and secure peripheral nerve suture with 10-0 nylon with 6 stitches was imperative to successful renovation. We must transfer for preschool children provided early and certain recovery and excellent functional recovery. Today, because of a shortage of presentation time, I did not report the detail of post-operative problems, that is elbow flexion contracture and limb length discrepancy. Please read our recent article published JHS European Volume 2018. The free functioning gracilis transfer is reliable reconstructive technique for reanimating upper extremity in preschool children capable of delivering stable function over a long period of time. Thank you for your attention.
Okay. Thank you, Dr. Doi, for your presentation. It has been an honor having you here making this presentation. And now I would like to ask people if someone has some questions to do to Dr. Doi. If not, maybe you can tell us something more about your postoperative control of the flap with CMAPs, because it's not so usual to do the control with CMAPs in I think in the rest of the world.
Can I show you some PowerPoint of a short presentation? Is okay? Concerning the CMAP.
Of course.
Okay?
Of course, Dr. Doi.
I will explain our post-operative management following Ferreyra transfer in preschool children. I introduce our approaches for vascular monitoring of grafted muscle, post-operative immobilization, and rehabilitation. We used only skin flap monitoring for grafted muscle vascularity before 2007. However, 8 cases, including 2 cases after 2007, developed post-operative vascular compromise. After revision of vascular anastomosis, 6 monitoring skin flap completely survived, but all 8 muscle grafts became partially or completely necrosis because of different susceptibility to ischemia between skin and muscle. We began to apply compound muscle potential CMAP monitoring in our clinical setting from 2007, an epidural electrode with 5 electrical points was placed in the subfascial plane of the muscle graft. Hourly CMAPs monitoring with simultaneously conventional skin flap monitoring by nurses in the ward was done for a period of 75 hours post-operatively. By monitoring the CMAP, a decrease of more than 50% in amplitude indicates vascular compromise, even if the skin flap does not show any changes. Using CMAP monitoring, we succeeded in salvage of all 8 vascular compromised flaps by CMAP monitoring. Conventional vascular monitoring could not detect all muscle graft with vascular compromise. CMAP monitoring could detect all muscle flaps with vascular compromise by showing 50% reduction of amplitude. The most important point to succeed in Freeman transfer procedure in adults is to continue the post-operative rehabilitation for at least 6 months and, if possible, 1 year in adult. Ideally, the patient will be attending the rehabilitation center, but the foam physiotherapy is also possible after being previously educated. However, this matter for preschool children is different and difficult to activate effort to strengthen the muscle power. We can only activate their daily playing and activities by parent cooperation. Post-operatively, the upper limb was immobilized with use of an sponge arm brace and cast, keeping for 4 weeks. The left side is a sponge splint for Freeman transfer with ICN transfer, keeping only the involved arm. The right slide is showing the CC7 transfer, in which the cervical immobilization with soft collar was added. This is also applicable for Freeman transfer with spinal access nerve transfer. A sponge splint for Freeman transfer followed arm sling after 5 weeks until active motion recovered. Post-operative rehabilitation. Early passive immobilization is imperative to prevent adhesion of transverse muscle tendon portion, especially for combined reconstruction, including the finger function reconstruction. Early passive mobilization starts 1 week post-operatively to prevent adhesion of the tendon suture. This is continued until there is evidence of muscle contraction, which usually occurs around 6 months. But this early mobilization is unnecessary for single elbow flexion reconstruction, in which only elbow flexion contracture should be prevented by gently passive elbow extension. This is a flowchart of a protocol following double Freeman transfer in adults, which included electrical stimulation to reduce the muscle atrophy, EMG biofeedback to educate the patient how to strengthen the individual transverse muscle, and so on. However, these items was impossible for preschool children. We only recommend passive range of motion exercise of elbow and shoulder to prevent the contractures. As you know, it is difficult to activate the preschool children to strengthen the muscle power by attending to the rehabilitation center, and we recommend the parents to activate children daily playing and activity as possible. Post-operative. It's better to stop here. Marian?
Okay. So
Any question?
yeah, I have some other questions. what about using intercostal nerve empowering elbow flexion and extension simultaneously? Do you have any issues with co-contraction? And
say again?
When you use intercostal nerve to flexion and extension, if do you have any issue, any problem with co-contraction? And if there is any suggestion on rehab?
I understand that you can imagine that co-contraction of biceps and grafted muscle and triceps, which was innervated the same intercostal nerve. But clinically, we did not experience such a co-contraction because that the triceps power little bit weak compared to the grafted muscle.
Okay. And I have a question also from Nuccio Catena. Which is your second plane if your flap doesn't work?
Which is complaint?
If the flap does not work, if there is another solution?
It's just for elbow flexion?
Yeah.
But depending on the type of palsy, if the total palsy of brachial plexus, we have no procedure develop. And maybe that upper type paralysis, if you can salvage the whole elbow flexion, like the triceps transfer or forearm muscle transfer, like the Steindler procedure.
Okay. And with the flaps, you have revascularized gracilis. The outcome is the same.
Which one?
The outcome of the revascularized gracilis is the same that the ones that didn't need revascularization.
After application of CMAP monitoring, we have the same result, same outcome of muscle powers. As long as vascular compromise, vascular anastomosis, the anastomosis was done within the 6 or 8 hours.
Oh, okay. So same outcomes.
Yes, same outcome. But if you don't use the CMAP monitoring, you apply only the skin flap monitoring, you missed.
Okay. I don't know if there are more questions. Maybe no. Okay, so I don't know. So Dr. Soldado, maybe we can pass to the other talk. I don't know.
Any question? I'm always worried to do the suture, the microsuture, in less than 1 hour. That's what some other people taught me. But so if the muscle is in ischemia more than 1 hour, or 2 hours, there is no problem. So you think that 6 hours would be okay to of ischemia for a gracilis transfer to have a proper function?
Yes, usually after harvesting the gracilis from the donor side, from the thigh, usually 2 or 3 hours escaped, but does not affect on the muscle contraction.
Okay.
You are talking about you are worrying about 6 or 8 hours ischemia.
Okay, thank you.
Maybe you don't understand my English.
No. That was the.
I think it is very different of my technique. That Marian asked me, what is my tips and tricks? I'd like to say that maybe nerve suture technique, it may be different from the European surgeons. We never used to the keeping glue sutures. Just I accustomed to suture only with the 10-0 nylon with six stitches. We never used Hebron glue. Maybe it is meticulous nerve suture is very imperative to get tremendous success. I'd like to emphasize this one.
Thank you very
Can I
much.
ask a question?
Okay.
Yes, of course, Professor Clifton, of course.
I'm sorry, I muted.
Oh. Good day, Professor Doi. It was a great lecture. Thank you very much, sir, for this wonderful lecture. I have two questions, sir. When we started doing intercostal for musculocutaneous, we started using two intercostals, but it seems that the outcome for that kind of transfer, it was better when we started using three, and then I started using 4 intercostals, not trying only to have a renervation of the biceps, but also of the brachialis. Do you see any difference in using 2 intercostals or maybe using 3 in the muscle power?
You are talking about just children or including adult?
Yes, include children and adults, yes.
Okay. I accustomed to suture the three intercostal nerve always. But sometimes recently I transferred the 4 intercostal nerve, but
Yes.
Including the 3rd, 4th, 5th intercostal nerve, and sometimes 6. But sometimes 6 intercostal nerve could not reach to the end of musculocutaneous nerve. So I recommend you 3 intercostal nerve is enough to get satisfactory outcomes. And sometimes, you know, that in children, sometimes we use only 2 intercostal nerve to get satisfactory result in children. Thank you.
Okay, and any secret and if you can give us any advice or any secret for immobilization of preschooler children, because sometimes in my country, in Mexico, small kids are very wild and they move a lot. So I don't know if you can give us any secret how to immobilize so they don't move like, you know, a lot the first postoperative days. Would you sedate them or do anything extra?
Okay. Your question is that in children, the children cannot immobilize their arm in the cast just after the operation.
Any
That is correct.
Any tricks to immobilize them? Any recommendations? Any tricks for a child to be immobilized?
Immobilize. I show that just a post-operative sponge cast, sponge splint. Did you see that?
Yes.
Okay. I think, thank you very much.
You know that, okay, thank you very much.
Thank you very much, Professor. It was
Okay, so-
an honor to have you in these sessions. So now we are going.
Good night.
Thank you very much. We are going to move to the next talk.